almost twice as common in Southern Europe compared to Northern Europe. So again, there is a definite relation to body size and the aortic valve implantation. So what is the problem with the small aortic annulus? Once we establish that the aortic annulus is small, we're going to put in a valve which is inherently obstructive into that small annulus. And this has also been shown in multiple publications, most recently popularized by Bo Yang when he demonstrated his new technique of root enlargement, that the inner diameter of the prosthetic valve is always 5 to 7 millimeters smaller than the labeled valve size. So that is the problem. And TAVR with the SAVR valves are more obstructive compared to TAVR. And even in the TAVR valves, balloon expandable valves have a high incidence of PPM compared to the self-expanding valves. So how to calculate this EOA? That has always been the issue, and there are two ways generally recommended. One is the conventional method, which is the measured EOA, which we do using the Doppler echocardiography. And then there's not a new concept, but probably the recommended concept should be something called the predicted EOAI. So the problem with the measured EOA, there's a lot of fallacies in its estimation. There's a lot of inter-observer variability. So one echocardiographer does an echo on one patient with a particular valve, and another echocardiographer does a same study on the same patient. He can have a completely different value for the EOA. So to avoid this inter-observer variability came this concept of the predicted EOA. In this technique, you do not need to do any echo measurements. You just take the reference value of the EA for that particular valve and that particular size of valve which you are planning to implant or which has already been implanted, and divide this EOA by the patient's body surface area. So then the question comes, where do I get these reference values? Surprisingly, even this is widely available in the literature, and this has been collected from multiple studies from CoreValve Ecolab estimations, and they've given the values of all the commonly implanted valves. So if you look at this, like the Carpentier-Edwards Perimount Magna valve, we'll just look at the size 19 valve. The EOA of that valve is 1.3. And another commonly implanted valve that we implant here, the BioCore, the Epic valve, if you look at the EOA of the 19 size valve, it's only 1. So it's significantly less than the Perimount. Coming to mechanical valves, the St. Jude region is a fantastic valve at the smaller size. If you see the EOA, it's 1.6. And when you compare that to any of the other mechanical valves, it far outperforms the other valves. Similar thing in the bioprosthetic field. If you look at in the size 19 valve, the Perimount valve does outperform all the other currently available bioprosthetic valves. So this is important because generally this is the chart that we have in our OT conventionally. This is actually provided by the valve companies. But when I went back and looked at the values provided by the valve companies, they're giving much higher EOAs, which is not correct. So it lulls us into a false sense of security that we're putting in a bigger enough size valve. But actually what we should be having in our OTs is maybe these kind of charts to give us an accurate prediction of whether the patient will have PPM post-implantation. So those who are interested, this is where I took this particular chart from. It's from the European Heart Journal in 2016. So what is the impact of PPM on survival? Yeah, it does have an impact. There are multiple large studies showing the effect of PPM, and the conclusions of these studies were that the increasing grades of PPM are associated with increased long-term mortality. Severe PPM was associated with increased heart failure, and moderate PPM, though common, its clinical significance may be negligible because the differences in clinical outcomes was small. So just quickly going through some data from our hospital. When I was just looking up, I was wondering what was our incidence of PPM. So I took number of AVR patients done for the last 7 years from 2017. The total number of patients were 399. Most commonly bioprosthetic valves were implanted. And our most common implanted valve size was the 21, followed closely by the 19 valve size. And if you look at the model, most commonly implanted bioprosthetic valve was the Perimount, and the most commonly implanted mechanical valve was the St. Jude Regent. So looking at our incidence of PPM, so again just looked at 17 and 19 valves. So taken just the 17 and 19 valves and looked at the incidence of PPM. So if you look at the St. Jude region, which comes in a 17 size, we had 23 patients which we put in a 17 size valve. Only one patient had severe PPM, which is quite good, amazing for that size annulus. And if you look at the 19 St. Jude region, we had 0 patients with severe PPM and only 4 patients had moderate PPM. So this is a fantastic valve for the small aortic annulus. And if you look at the bioprosthetic valves, one surprising finding was the EPIC performs extremely poorly at the 19 size. So we put in 14 valves of a 19 EPIC, and among those 11 had severe PPM. Whereas in the perimount, the 19 perimount, none of them had severe PPM, but a good number of patients had moderate PPM. So our incidence in the overall group of patients was, I'm just mentioning this is just the 17 and 19 size. Out of the 132 patients, 12 had severe PPM. So it leads to an incidence of 9%, but this is primarily driven by the high incidence in the 19 EPIC valve. Again, in our cohort, moderate PPM most common. 53% of the patients had moderate PPM, but again, that was driven mainly by the 19 perimount. What is the clinical relevance of this? We'll have to follow up. So how can we mitigate this risk of PPM? One is obviously a complete debridement of all the leaflets and the calcium in the annulus. Suture techniques we can modify, use non-pledgeted sutures, use simple sutures, use continuous sutures that facilitate a bigger valve being implanted. Choice of valve, again, we have multiple choices now, so ensure you can use a supraannular placement. Mechanical valves have a better EOS, so mechanical over bioprosthetic. Otherwise, use a sutureless bioprosthetic or a stentless bioprosthesis, or even consider TAVR valve in an elderly patient with a small root. But then it comes on to the last and not the least, our topic of today's wet lab, aortic root enlargement. So aortic root enlargement is basically categorized into 2 types, the posterior root enlargement and the anterior root enlargement. That's based on where in the aortic annulus you make your incision. So it's divided into an anterior and a posterior root, and the most common done by the adult cardiac surgeons is the posterior root enlargement. So there are 4 techniques in the posterior root enlargement: the Nix, the Nunes procedure, which is the modified Manugian, the Manugian, and the newer procedure, the Bow-Yang technique. The Nix procedure was the first described technique in 1970, which is basically an incision made in the middle of the non-coronary sinus, just extending across the annulus, just across the annulus. The other 3 techniques of posterior root enlargement are done. The incision is made at the junction between the left and the non in that commissure, and the difference in the techniques is the extent of the incision. Wherein the Nunes is exactly similar to Nix procedure, where you just go up to and across the annulus, whereas for the Manugian, you go much farther in, you cross the aortomitral curtain and also enter into the base of the anterior mitral leaflet. Concomitant with this, you also enter into the roof of the left atrium. Whereas in the Bow-Yang, you go into the aortomitral curtain and the incision is extended laterally on both sides beneath the non-coronary and the right coronary sinus. The anterior root enlargement is the Kono-Rastan. This is more commonly performed in the pediatric patients, but can also be done in an adult patient where the incision is made to the to the left of the right coronary ostium. So the operative steps, I'll just skip here, but the basic setup is just like an AVR. Once you do your aortotomy, you decide which type of enlargement you want and extend the aortotomy in that direction. So as mentioned earlier, the Nix, the incision is made in the middle of the non-coronary sinus, whereas in the Manugian, you go across the LCC, NCC commissure into the base of the AML. And then into that defect you create, you sew in your patch. You sew in a patch. We'll discuss about which patch to use during the wet lab. Size the annulus, place your valve sutures, and implant the valve. The Bow-Yang technique is a newer technique described 3 or 4 years ago, which is another type of root enlargement through the LCC, NCC commissure. But instead of the Nunes or the Manugian, You make your incision into the aortomitral curtain and then extend it on both sides beneath the both sinuses of non-coronary and the left coronary sinus. So this allows us to actually put in a much larger valve because you sew in a rectangular piece of whatever material you use and implant a much bigger valve size. The conorastan, like I mentioned, is more commonly performed in the pediatric population. The incision, like I mentioned, is to the left of the right coronary artery. It extends across the annulus into the RVOT, and then you open into the interventricular septum. So you are opening both the RV and the LV in this procedure. Then you patch the interventricular opening that you have created and extend that patch across the annulus to enlarge your root. And then, like the other steps of the other procedure, size the annulus, put in your valve, and then close the RVOT with a second patch. So just a quick comparison. If you do look at the Nix and the Nunes, the degree of enlargement is much less compared to the other two. You can generally go up by one valve size, but it's easier to do. But the disadvantage is that only one valve size up you can go. The Manugian, a little more complicated procedure, but you can go up probably up to 2 valve sizes, but it's more complicated. You can have mitral valve problems and more chances of bleeding. The Bo-Yang technique, it's been reported that you can go up to even 5 valve sizes, so it enables a much larger valve. And one advantage it has over the previous techniques is that you can also be done in the patient with a prior mitral valve replacement. Problems are again bleeding, and there are some reports about the valve being tilted. It can cause problems in future for the valve in valve TAVI if required. And coming to the last procedure, the conorastan, the degree of enlargement is something in between, around 3 valve sizes, but it's a much more complex procedure. It can be injury to the septal LAD, and you can have a residual VSD. But this procedure can also be done in a patient with a prior mitral valve replacement. So what is the data on whether we should enlarge or not to enlarge the root? Again, lot of publications. Basically, the conclusion is conflicting findings on whether a root enlargement causes any increase in mortality, but all papers agree that it decreases the incidence of PPM. So take-home messages. So small aortic annulus by definition is implanting a valve size less than 23, but probably in an Indian setup, we should think of a valve size less than 21. Prosthesis patient mismatch is real, but clinical significance is only probably present when it is severe. When doing only valve replacement, choose which valve you implant wisely. And aortic root enlargement is relatively safe and cost-effective way of mitigating PPM. Thank you.